of botulinum toxin is the possibility of producing dysphagia, and I've never done it myself, but I've seen it in patients with a nasogenic treatment with a frightening prospect. But in fact, if you're careful, it's an incredibly safe treatment, and once you're getting good at doing necks and arms, I recommend that you don't shy away from these possibilities. Now, a movement disorder talk is not a proper movement disorder talk unless we have a failure in the video at some point. And so I have the honour of having a failed video today, but I think we've figured out a way of doing this. Now, it's important to recognise that dystonia is not simply an abnormal muscle contraction. It's an abnormal motor planning problem based from the brain. And when we look at this woman who has difficulty opening her mouth, that you'll see from her gestures and the way she's doing it, it's not just that she can't open her mouth, it's as though she doesn't know how to open her mouth. So here I'm asking her to open her mouth, and she's just concentrating, she moves her lips, she grimaces, but she just doesn't know how to do it. There's something being truncated with this video, I'll just show you again. As I said, it's as though she doesn't even know how to open her mouth. And she's got a trick, and the trick is she uses a spoon to get her mouth open. So this is the version of a sensory trick. It doesn't work perfectly, but it does actually allow her to get her jaw open, and this is how she feeds herself. So she talks through her teeth, and she puts the spoon to her mouth, and then the jaw opens just enough so that she can get the spoon in. And so, as I say, it's not just a muscle spasm disorder. Now, one of the interesting things about treating dystonia is sometimes you can break a cycle. So there are basically 3 muscles that you can inject if the person can't open their mouth. And the 2 superficial ones, and this is the easiest of the oromandibular injections to give, and probably anybody with any comfort in injecting botulinum toxin should be able to inject these muscles. So the temporalis and the masseter, and then inside there's a medial pterygoid, which I'll come back to in a moment, but you wouldn't bother with a patient like this. You can inject both muscles easily. What we tend to do is make up our minds as we go along, and usually one set of muscles is bulkier than the other, implying that this is the overactive muscle. And there's no science in this. In fact, one of the interesting things about botulinum toxin, once you get past the initial evidence that it works or it doesn't, there's actually very little evidence base to help you in any muscle selection group. And you have to base it on your knowledge of anatomy and what muscles do. So this woman, we injected her masseter muscle, and she got 40 units of Allergan Botox on either side. And it's quite a simple injection pattern, just above and below, a couple of finger breadths above. You actually pierce through the parotid, but if you go into the muscle, the patients don't seem to have trouble with dry mouth, interestingly. And this is what she's like 4 weeks after her botulinum toxin. She's still almost as though she has to think about what to do, but she can now get her mouth open. You see her thinking? She has to almost work through the process. And so this is one of the features of dystonia versus, say, a spastic or some other form of autism. She can now speak better than she could before, and much easier to feed herself. So for her, this is a major improvement. And she's been receiving botulinum toxin, same pattern for a number of years now, and gets the same sort of response. So that's an easy muscle injection pattern. You really can't particularly go wrong with injecting the masseters bilaterally. And if you need to, you can also do the temporalis muscles. If you do the temporalis muscles, I warn you that you'll get a lot of wasting, and it's worthwhile to give the injection behind the hairline, because patients don't like it otherwise. They get a large concave area in the side of their skull. Now, here's another patient. She's got jaw opening dystonia. See her jaw open like that?
I've been lazy, not doing the exercises on, sometimes I try and do that. Oh well.
He has to pause, the jaw's open, and it's pushed open, the jaw's pushed forward as
Cơ
well.
cắn
You
kéo.
can see the temporomandibular joints
Does the
bulging
jaw
up here.
ever lock closed or lock open as if you can't move?
So I'll just run through that one more time. And so what I want you to see is the jaw doesn't just open, it sort of thrusts forward, particularly the temporomandibular joints. Okay? And I also want you to recognize that she has a segmental dystonia. She's doing eyelid blinking and she's doing screwing up her face at the same time.
When I feel pain, it's happening 2 months or something.
See her face screwing up?
And I
And what's the temporomandibular joint?
No.
See it thrusts forward like that? So the whole jaw is pushed forward.
You know, and sometimes I find do that. Oh well.
Với cơ gì? Cơ cắn ở dưới.
And she's got some abnormal tongue movements as well. A patient like this would be something you'd be very interested in the history. What would you be asking her? Is she taking notes, yeah? The answer is no, she's got a neopathic form. You would for sure be asking this question. Now, there's 2 sets of muscles that you have to think about in a patient like this, and this is the one set that she doesn't have. So the muscles, the inframandibular muscles, particularly the digastric muscles. If you look in the textbooks, it suggests that these muscles are involved with jaw opening, but they're actually only involved with jaw opening and pulling the jaw back. In fact, you can test it on yourself. If you're trying to thrust your jaw forward and open your mouth, you don't get the same degree of contraction in these submandibular muscles. And so what's pulling her jaw down and thrusting it forward are the lateral pterygoid muscles, these ones here. And they sit behind the ramius of the jaw. So the jaw's been dissected away in this patient. Here's, and in here, the lateral pterygoid muscles. This is the medial pterygoid down here, just to show you from a different angle. So this is looking from behind. So there is the jaw, that's the temporomandibular joint, and here are the lateral pterygoid muscles here. The medials here, so the medials are jaw closures. And both these muscles, so the lateral here is the jaw opener, and particularly in this woman, because it opens and pushes the jaw forward at the same time. Both of these will cause movement of the jaw to one side if there's asymmetrical movement. So the patient who thrusts their jaw across, they'll be getting contractions on this side, pulling the jaw over. So when you get a patient with a jaw opening dystonia, you want to look for lateral movement as well. And it's very similar to the last talk we did from here. You want to try to work out what the pattern of movement is, and then decide what the muscle is that's producing this pattern of movement. Now this is a tricky muscle to get, but if you can, it gives you some satisfaction and also fame amongst your colleagues, because what you have to do is get it by going through the notch in the jaw. So the lateral pterygoid muscle is behind this notch here. And you can expose it by getting the patient to open their mouth, and the notch gets larger, and you inject halfway along the zygomatic arch. And some patients have got a prominent notch here, and you can actually feel that notch, which gives you some more guidance. If you do a CAT scan first, this is from a paper from Hihi, you can show schematically some needle tracks going into the lateral pterygoid muscles, which are here and here. See, this is the temporomandibular joint here, and you can see the muscle. So you want to go through the notch and aim backwards slightly. And you're aiming for the muscle here. And once again, this part of the jaw has been amputated to allow you to see the muscle. So I'm imitating the notch with my fingers here, and so as she opens the jaw, the notch opens. I find the zygomatic arch, go halfway along, the needle goes in, and then aim posteriorly. And what you'll do is, you know you're in if you use a 1-inch needle, because if you're not, you'll hit the bone, you'll hit the jaw. And so you hunt around, then you thrust through, and you go right up to the hilt of a 1-inch needle. You can use EMG, and you should when you're learning, but once you've learned how to do this, it's actually a very simple technique. The other way to reach this muscle is transorally, but I don't do that. This is the only technique I use. And for patients with jaw opening dystonia, I use, once again, the only toxin formulation I use is the Allergan Botox formulation, and I would start off with 15 units on either side, or asymmetrical if the patient's jaw is moving across. And she and the other woman get a wonderful response, which works in the same sort of duration of effect that we've been discussing before. So it comes on over about 7 days, and the law of sevens, I think that's a great thing. Now this is a patient with drug-induced jaw dystonia. And she's using a sensory trick to try to close the mouth.
Ừ.
Yeah. Yeah, mate. And she's got much more than that. She also can't handle food in her mouth, so her tongue is causing her a great degree of problem. And she's also lost some of her swallowing mechanism too, as you'll see in a moment. So she can't swallow. And then like a seabird, she throws her head back to do this. Now we helped her jaw opening with the botulinum toxin, but we didn't help her swallowing, and we didn't give her any function back because she had such a complicated problem with her tongue and oropharynx. So you just have to think your way through what are the actual problems the patient has. For the other two, it was pure jaw opening, easily treated with a botulinum toxin. Here, a complex pattern of movements that we attempted to help with the botulinum toxin, but it didn't give her much benefit. Now, the second part of my talk is spasmodic dysphonia. And the frequency of this varies depending on the surveys, but probably about 5 people per 100,000 get this. So probably about 1 or 2, perhaps up to 10% of dystonias will get this disorder. And we see 2 patterns of spasmodic dysphonia or dystonic dysphonia, and it depends on whether the vocal cords are pulled together, which is adductor dysphonia, or whether they're pulled apart. And in fact, if you think of them just as being pulled together, adductor or apart, then you can easily understand what the patient will get. So if the vocal cords were pulled together, they would cause a tight, strangled speech, a bit like this, because they can't get the voice out through the tight vocal cords. Now this is a dystonia, and dystonias tend to be specific for a certain task. So these patients can often cough, and sometimes they can even sing normally, because that's a different neuronal mechanism causing the spasm. If they've got trouble with coughing and emotional speech, then you have to wonder if there's actually a local cause on the vocal cord itself causing the adductor spasm, rather than a neuronal connection that we understand as the cause of dystonia. A good question to ask patients is it worse speaking on the telephone? And I don't know why, but patients with adductor dysphonia often describe this. Now this is a disorder that you have to, well, in my country anyway, you have to look after in conjunction with an ENT or an ORL surgeon. So the vocal cords have to be visualised, you have to make sure that there's not local pathology. And if you're going to give the injection, well, you probably shouldn't without an experienced operator doing it with you. And in fact, we do our injections in partnership with our ORL specialists. We worry about causing dysphagia, and we worry about local reactions. But I'm going to talk to you about how we do these injections anyway. So, you heard the and again, yeah, and a low E. She's got 2 problems: dysphonia and a bad loudspeaker system, which makes things worse. So the 2 things that you should have heard is she was speaking like this, and the particular trick to bring this out is to get them to do a high E. E, and they go E. It's a very strangulated sound, and these are the particular tests for this form of dystonia. And so here are the vocal cords, and there's the thyroarytenoid muscle, which lives along this edge here, which is the main cause of the abnormal contraction and the site for the botulinum toxin injection. We do the injection in our clinic this way. It's called the rose position. We stand above the patient's head and inject with the right hand facing back. But you'll see some people, and some of the ENT surgeons prefer to do patients sitting up, and it doesn't matter. It's a matter of really what you get good at. We like this technique because we can visualise the angle of the vocal cord and the angle along it, but it's whatever you like best. There are a number of tricks to doing the botulinum toxin. I'll just come back to this in a moment. And what you're trying to do is aim the needle in and track along the TA muscle here and inject it. And the TA muscle is up behind the thyroid cartilage. If you're good, you can get the needle in and run along without entering the airway. If so, it's not a particularly troublesome experience for the patient.